small group for today.
Hello, everybody. Just getting started with our rounds today with Dr. Joan Seri. Dr. Seri is an occupational medicine specialist and expert in extreme environments. She also has a cottage in this area, and so we're very fortunate to be able to tap into Dr. Seri and her expertise, and I'll hand it over.
Yeah, thanks, Kathy. I enjoy coming and participating and getting to know this community and to be able to give a little bit back to the community. So thanks for the kind welcome. I'm going to talk a little bit about, I called it occupational genetics. We'll talk a little bit about some primer stuff first. I will disclose, of course, that I am not a geneticist. This is me talking from an occupational perspective, and I hope really the main thing that you'll get out of this, even though I list the learning objectives there, the main thing I think is that I hope this talk ends up being essentially some food for thought to just give you a sense perhaps of the lay of the land a little bit. Oops, sorry, I see my slides are progressing at will. So let's take a look at genetics from the beginning. It took 13 years and billions probably to sequence the first genome in 2003. And now it's quite inexpensive and doesn't take very long to do. These numbers just keep going down over the course of time. Thinking back to what genetics is, Watson and Crick, they determined the structure of DNA back in 1953. It's this double helix with 4 types of nucleotides. I don't know the background of everyone in the audience, but we'll start with a just basic primer. So genetic information exists in the sequence of those nucleotides, and discrete regions of DNA that encode for proteins are called gene. The gene is the basic physical and functional unit of heredity, and they act as the instructions to make the molecules of protein. So DNA has a simple method of replication. It duplicates genetic information by essentially splitting the strands and using each strand as a template for the synthesis of the new partner strand. And the DNA of the chromosome is associated with structural proteins as well that organize, compact, and control access to the DNA. So I'm going to show you a video now. I hope it'll work. It worked in our trial without any problem. So here we go.
Using computer animation based on the latest research, we are now able to see how DNA is actually copied in living cells. You are looking at an assembly line of amazing miniature biochemical machines that are pulling apart the DNA double helix and cranking out a copy of each strand. The DNA to be copied enters the production line from bottom left. The whirling blue molecular machine is called helicase. It spins the DNA as fast as a jet engine as it unwinds the double helix into 2 strands. One strand is copied continuously and can be seen spooling off to the right. Things are not so simple for the other strand because it must be copied backwards. It is drawn out repeatedly in loops and copied one section at a time. The end result is 2 new DNA molecules. It's similar to copying information on a computer.
Okay, I'm gonna leave it at that for the video. Oops. and move on to talk about a concept that's pretty important for the nature of this talk, which is the concept of mutation. So during that process of DNA replication, which you can see how fast it happens, errors can occur in that polymerization of that second strand, and that can affect the way proteins are encoded. And so if there are mutagenic chemicals in one's environment, that can promote errors in the DNA replication, and that often interferes with the structure of that base pairing. And so cells use that repair mechanisms to generally repair mismatches, but sometimes the repair doesn't restore the original sequence. So protein structures are the result of amino acid sequences, and single nucleotide differences within the DNA can cause a change in the amino acid sequence. And those sequence changes can alter the protein's properties, and that's by destabilizing the structure, changing the structure, and this affects its interaction with other proteins and molecules. An example would be sickle cell anemia. That's a human genetic disease. It results from a single base difference within the coding region for the beta globin section of hemoglobin, causing a single amino acid change, and it changes hemoglobin's physical properties as a result. So the line between acquired and inherited genetic effects is sometimes unclear. So even if there are genetic mutations linked to a specific exposure, like all types of biological effects, like the host genetics also has mechanisms to regulate absorption, metabolism, and excretion of chemical substances to which one may be exposed, either at work or as part of one's hobbies as well. And a popular method for determining how genes in the environment contribute to those phenotypes is by studying identical twins. So I just, because Kathy didn't say it, but some of you know my background, that I work as a contractor for the Canadian Space Agency, so I tend to bring some of the space background in when I can. NASA has, this is in the past, is to conduct, but it's in the past now, they've already done it, conduct a twin study with two astronaut brothers who are identical twins, and one was flying a one-year mission, and the other one was staying on the ground. So I have another video. In the beginning of this video, I'm going to pull the video along. So give me a second while I just move the start bar to a better spot in the video. I'm going to take it off to about 2 minutes and about 11, and we'll start the video right about here.
The twin study is that we'll be able to tell what factors are causing environmental influence on a person and their health, and which ones are really genetic. They're identical twins, meaning they largely have the exact same DNA. And so when one goes into space, he's undergoing a certain environmental stress, undergoing the forces of space, whereas the other one's living a normal life on the ground. These guys are essentially genetically identical, so any differences they have are due to environmental encounters. If we're going to send someone on a 3-year mission to Mars, we really have to understand in detail what's going to happen to them and how to best keep them healthy. This will be incredibly relevant to us on Earth because essentially, as we see how people are living in space and the kinds of genetic factors that can help protect people in space, some of those same things will be very valuable for people on Earth. By reading your DNA, we hope to see what kinds of diseases you're at risk for, what kinds of genetic information protect you to certain kinds of stresses is really valuable just in general.
All right. Now, so they have completed that test now. They're analyzing the data. They've done some of the analytics already. One of the reasons for trying to figure out whether or not we can actually do some genetic sequencing is to determine whether or not astronauts will be able to do that in flight for longer duration missions. Can we actually not have to send the information to the ground, but can it be done in flight, that we could real time pay attention to whether or not some changes are happening? So personalized medicine might play a role in how to keep people healthy in long duration spaceflight. For example, screening for susceptibility to certain cancers might be particularly relevant. That, of course, plays into how we can apply that to our own daily lives. So I want to switch a little bit, talk about the types of genetic tests. This slide is busy. Just look at the dark highlights on the types of genetic tests that are available. And I think there's easy familiarity with diagnostic testing. And then there's fairly reasonable familiarity with prenatal testing and newborn screening, but the predictive and pre-symptomatic genetic tests are becoming more and more common. Carrier testing as well. And well, of course, research, but the pharmacogenetic testing about tests how a person's own makeup affects their metabolism and the effectiveness of medications that they're prescribed. And so certain medications may work better or worse in some individuals depending on their genetic makeup. This slide, it basically reiterates in a different way the same set of concepts in the wide variety of types of genetic tests that are available, and therefore, of course, the uses of those tests. So now I want to just enlighten you a little bit on the fact that, and I know many of you are not necessarily occupational physicians, but you will all have patients who will be educating themselves with the internet. Oops, sorry. And so there'll be lots of folks who'll be wanting to understand their own genetics and finding material online. And so hopefully some of this information will be useful to you. An example of the kind of thing that folks may be getting wind of either themselves online or in the lay press are things like different types of genotypes that will, for example, the FTO genotype is a predictor of body weight maintenance. And so in studies that examine associations between fat mass and obesity related genes over a 5-year period, discover that certain gene makeups, whether or not they're homozygous or heterozygous for a certain allele, will lead to difficulty in preventing fat gain from recurring after weight loss prevention, for example. So you can see if individuals are interested in losing weight and wondering whether or not they might have a genetic predisposition to not being able to keep weight off after they've lost weight. The answer is probably potentially yes, but they would never know unless they identified the gene for it. And furthermore, you know, lots of folks are interested in selecting a diet that suits them. Should they do intermittent fasting? Should they have a high protein diet, or should they avoid carbohydrates, or should they have a Mediterranean diet? There's an entire field developing in nutrigenomics that looks at different types of genes and determines whether or not certain diet compositions are better or worse for a particular individual. ApoE gene, this being one example, an endless debate over the different types of diets and whether or not the ApoE gene can elaborate any information that could be clinically relevant for clinicians as a result of that. And so my next few slides will just show you the kind of thing that your patients or even yourself might be finding and undertaking with the available DNA testing that's just direct-to-consumer testing on the market now. So there are these learning about your heritage and your origins. There are labs that are advertising, scheduling an appointment for various genetic testing availabilities. For example, and I'm not sure if this is, I downloaded this some time ago, so I'm not sure if the actual price is correct, but certainly phone the 1-800 number and you can find out whether or not you have the BRCA1 gene, independent of whether or not you as the clinician have ordered that. The patient might show up to your office saying, here's my test result, what do we do now? And Life Labs, and in case you in case you didn't know that Life Labs can do this, there is a link on the bottom there, or a website, lifelabsgenetics.com, where you can access requisitions, consent forms, payment forms, and funding applications for genetic tests for reproductive health, for cancer, and for hereditary conditions in your patients. More examples of a different variety of tests that are available and the type of results that might show up from that, where you end up, where you or your patient might end up with a summary of some physical genetic profile that reflects, you can see in the slide, the athletic potential and potential for hair loss and memory capacity and lifespan, and then behavioral. And so various testing businesses will break down the results for the purchaser in a variety of different ways. Here's another one that many people may have heard of, 23andMe, and you'll see that they break down the results a little bit differently. They identify and break the results down into genetic health risks and carrier status, which gives you a sense of the type of genes they're testing there. Wellness is how they derive some of those things that in the other company identified those as physical versus psychosocial, or whatever they called the other one, and traits. So I bring to your attention the Choosing Wisely Canada concept, where different specialties in Canada have made comments about what not to do, and the group, the genetics group, has made a specific comment about don't make medical decisions based on results of direct-to-consumer genetic testing without a clear understanding of the limitations and the validity of that test. And you can see the reasons why. You know, because many of the protective factors or genetic risks are multifactorial. Some of the companies actually don't guarantee the accuracy and reliability of the testing. And so even in the same person, if you ordered a test from company A or from company B, you could end up having different risk interpretations between the companies, even when those tests are performed, as I said, on the same individual. So now let's take a bit of a step back, because of course I said this talk was about occupational genetics. I want to link into something called epigenetics. It links the environment and genetic influences on traits and characteristics. of a person. And although the epigenetic hazards don't change the genetic code per se, they can impact the genetic sequence, and that in turn affects whether, when, and how specific segments of the genetic code are activated or expressed. So there's a bit of an on-off switch with certain components of the genome. So although the genes contain all that information, the environment can play a role in determining that. Another important point that maybe some people don't, they probably have a sense of it, but maybe don't consciously think of it so much, is that genes can be unexpressed as well through the same mechanism. They make them inaccessible to cellular processing. The strategy is called gene silencing. So I have another video for you about epigenetics. It's about 3 minutes long or so.
Did you know your environment has a profound impact on your DNA and your health? Basically, everything you do, your exercise, the food you eat, the various life stresses, can impact your DNA directly. Your environment can either chemically modify your DNA, or it can in fact affect the way it's packaged. It can modify the packaging material that surrounds your DNA and determines whether genes are turned on and off. Now, the collection of modifications, either the direct effect of modifying the DNA or modifying the packaging material, is called epigenomics. It basically is highly cued by the environmental influences that impact it. In fact, what you may not realize is that your aging is a genetically determined response. You don't just wear out. You, in fact, are programmed to get old and die. And so people are trying to actually figure out how to control this so that they can basically live longer, healthier lives. So when astronauts go into space, they undergo incredible stress, and they're also exposed to radiation. In space, people are very concerned that aging actually may be accelerated by all the radiation damage that occurs. And so one thing you can follow is, in fact, the ends of people's chromosomes are called the telomeres. And the telomeres are very important for protecting the ends of your DNA, and they're thought to be useful for protecting aging as well. And so one of the things we'll be doing is following people's telomeres as they're in space. One of the other things we'll be doing is following the collection of these epigenetic changes. And the reason we're doing that is because we know that they are modified by stress. And so we'd like to understand, as Scott is traveling in space, what kinds of changes might occur on the DNA or on the material that's packaging the DNA. And we'd like to see how those changes are occurring, again, under these various stresses, after a liftoff, after radiation exposure, after just living a long time in space, and after eating just a very defined diet. We'll also see how they change or revert back after he returns to Earth. Why is this useful for people on Earth? Just as in space, for people on Earth, we want to understand how stress responses directly influence people's DNA. We want to understand these epigenomic changes that occur. We want to understand which ones will be permanent and which ones will be temporary. And ideally, we want to understand this information so we can better manage people's health. If we see certain kind of perturbations in their DNA, we might be able to treat them differently than if we didn't have this information. So in summary, epigenomics is really important. It may in fact be more valuable than understanding your DNA itself, because how you actually change your DNA through your habits, through the food you eat, through your exercise, through how you age, is ultimately going to be very valuable for managing your health.
All right. So with that, I want to then take a step into the occupational or maybe environmental part about it. You know, there are a lot of chemical agents that we continually learn more and more about, and more agents get added to the list of carcinogenic risks to humans over the course of time. And this is not a lecture on carcinogenicity, but certainly genetics and carcinogenicity are two topics that are interleaved. So chromosomal aberrations in human peripheral lymphocytes have been associated with some occupational exposures for decades. We've known about them for a long time. So the concept that genetics would be involved in occupational exposures or in environmental exposures is not really a new one, but it isn't really consolidated perhaps in our thought process in clinical practice. So this genetics in the workplace document dates back to 2010 from the CDC. So we're now like, it's a decade since this kind of thinking has been well established. And I know this slide, even on my own computer, I'm seeing that it's a bit maybe blurry. So apologies for that. But just perhaps a more important note to get from this is genetic polymorphisms in occupational disease there are many of them, and the exposures that cause them, you know, the link between, for example, aromatic amines and bladder cancer is well known. What we're learning more about now is the reason. And the reason is the genetic factors. And so as we learn about occupational cancers, bladder cancer, lung cancer, mesothelioma, you know, toxicity to the kidney and to the brain, and many of the other effects of workplace exposures, we were aware of the fact that they were associated with cancers and that there was that link. But now, as time goes on, we start to understand the actual genetic polymorphism that plays into that. Here are some more examples of occupational exposures that are known to be influenced by genetic factors. I don't know in the Parry Sound region whether or not there's a ton of industry that would trigger a lot of these exposures. Certainly some of them, though, are near universal. When you think about noise, for example, I think the fact that there's a genetic factor associated with noise-induced hearing loss is something perhaps most people didn't pay attention to or have awareness of. So how do we know then? How do we find out what is going on? If someone has or hasn't been exposed, there are also genetic ways to evaluate whether or not an individual has been exposed, as opposed to whether or not they have a disease. So we can identify a variety of changes in the genetic biomarkers that confirm that there has been an exposure to a particular either environmental or occupational chemical. So for example, if someone is working with roofing asphalt, which is a fairly common exposure, most people have roofs on their houses, or industrial roofing, DNA strand breaks can be identified as a biomarker to indicate that that particular individual has been exposed. Similarly, one can identify genetic biomarker changes for exposure to X-rays, so radiation, which is important. Cisplatin are the kind of things that may be important for those working in hospitals who may have occupational exposure in a hospital. But of course, nothing's ever simple. So this is just one example of the interactions between a bunch of etiologic factors that contribute to non-Hodgkin lymphoma subtypes. And the environmental and occupational exposure is thought to play a role in affecting one's autoimmune disease, the acquisition of oncogenic genetic lesions, and altering the inflammatory or immune milieu. And you can see as well that host genetics and lifestyle factors will also affect those items. So it's a complex interaction, but non-Hodgkin's lymphoma, there have been numerous papers, and these are now some years old. Some of these are dating back to 2012, 2014 timeframe, showing that there are biomarkers of susceptibility to chemical carcinogens, and that's specific for non-Hodgkin's lymphoma. There's also interactions of occupational exposure with some of the genes, which is also adding to the complexity that, if an individual carries a certain genotype, they may have an increased susceptibility to some exposures. Another example is contact dermatitis. Often, we think about it in terms of the allergic or the irritant type of dermatitis, and how dermatologically the skin and the immune system interacts. But what about genetic susceptibility markers? So there's a large table worth of gene and alleles that have been associated with various skin sensitizers and susceptibility to those. Wouldn't it be nice if you knew you had allergic contact dermatitis, that you had a particular gene that made you specifically sensitive? It'd be nice if you knew that before you had the exposure and developed the disease, perhaps. Here's an interesting one, because noise is such a ubiquitous exposure that certain genotypes would be risk factors for noise, and that the noise-induced hearing loss, and that they interact. So the interaction between noise and hypertension has been speculated and identified, but the fact that there is some sort of genetic polymorphism underlying the whole thing is really quite an interesting discovery. I mentioned beryllium before. I'm not sure in the Parry Sound area there's too much exposure to beryllium. Beryllium is a metal that's often integrated into alloys, for example, and it's heat resistant and very hard. So you see it often in sort of aviation braking systems and that kind of thing. But beryllium sensitivity is has been linked to a specific genotype. So that specific genotype, well, I'll remind you, a genotype is an individual's collection of genes. And so that term can refer to the two alleles or a particular gene. But beryllium is really the first industrial toxicant for which there's a scientifically valid genetic susceptibility test that could be done. So the gold's, oops, sorry about that. I'm not sure. There we go. Okay, the gold standard for screening is the positive predictive value. That represents the proportion of subjects with a positive test that actually have the disease. And certain rare alleles are identified with positive predictive values up to 100%. So in other words, we have a test that is valid, and we have a way in that test with up to 100% certainty detect that if they have a certain allele, they will be guaranteed to have an illness. That suggests there's value in doing that test. This is just another example of the beryllium, a beryllium example. And here in the highlight, high prevalences of beryllium disease are associated with certain alleles, and suggest that workers may, these authors suggest that workers may benefit from knowing their genetic susceptibility in deciding whether they would like to avoid future beryllium exposure. So they would have a choice in what work they chose to do. So most diseases involve a complex system of gene pathways that are not represented by such a simple single gene polymorphism. However, if a gene characteristic can be linked to increased risk in populations, should this be used for the basis of an occupational exposure limit? Generally, occupational exposure limits are set with the assumption that essentially all employees are of similar risk. So I want to remind you about occupational health and safety legislation, which you hopefully are aware that this legislation exists. But occupational health and safety legislation mandates that to the extent it's feasible, employees will not suffer material impairment to their health as a result of work. And now OSHA admittedly is in the US, but there's Canadian legislation that's just the same, has not been developed with the explicit concern for individual variability in response to hazardous substances. So the standards are based on the assumption, as I mentioned, that all employees are of similar risk. Of course, so the implication of that is that there have been no occupational exposure limits based on the genetic characteristics in subgroups of the population. There's no occupational exposure limit for a genetic subpopulation, even though studies suggest that some people may have susceptibility that puts them at risk below the established occupational exposure limits. And so this concept that there is a single threshold that delineates safe from unsafe to levels of non-carcinogens or even carcinogens, but primarily we're talking non-carcinogens because the no safe level for carcinogens may be assumed. That is increasingly difficult to support, that there's a single threshold that can delineate safe from unsafe as we start to learn more about genetically susceptible subgroups. So if it's not really feasible to control risk to the background level, then there may be pressure to invoke cost considerations as the reason why various genetically defined subgroups may not receive maximum presentation. We need to avoid then the simplistic view that genetic or epigenetic factors are the primary cause of occupational disease. Occupational exposures are the primary cause of occupational disease, and that remains the responsibility of the employer to control them. However, occupational information could really be a useful tool for increasing the precision of the risk assessment and the protectiveness of occupational health standards. So I'll take a moment. I'm not a lawyer. I'm also not a geneticist. But I'll talk briefly about the Genetic Non-Discrimination Act, or Bill S-201, that was passed into law in 2017. And this bill, along with amendments in the Canadian Labour Code and the Canadian Human Rights Act, prohibits companies and employers from requiring genetic testing or the results of genetic tests, and prevents companies from denying service based on the result of genetic testing. So this is a non-discrimination act. Similarly, in the US, there's the GINA Act. People may be familiar with the GINA legislation in the US. And so some occupational organizations have come up with position statements related to occupational testing, genetic testing in the occupational realm. And ACOM, which is an American occupational Medical Association has taken the position that genetic screening is not conceptually different from other types of medical testing. And so if one adheres to ethical standards and good scientific practice, one obeys the law, then including medical confidentiality laws and protecting the rights of individuals, that new information may be useful and may allow further safeguarding of people's health in the workplace, particularly if it's offered on a voluntary basis. Because really genetic information is a form of health information like a lot of other health information. And as clinical genetics develops, it's going to become increasingly difficult to distinguish it from other forms of health information. And I often ask people to think about, when you take a family history, are you really taking a genetic history? As you ask people about, is there anyone in your family, are there any males in your family that have had a cardiac event under the age of 50, are you asking about family history? Are you really taking a genetic history? To some extent, we get a lot of genetic information. We just like to not call it that. So we already have a lot of genetic knowledge with different tests. And so measuring the outcome caused by a genetic anomaly is still identifying the presence of genetic susceptibility, just not proving the presence of the gene. So how can we identify some genetic and hereditary disorders? You know, if you do lab tests for sickle cell, if you do color vision testing, if you do a clinical exam for the TRAP symptoms of Parkinson's, you're really actually kind of looking at genetic testing in a different way. You're just not looking at the gene. So it seems reasonable to expect then that in the future, some forms of genetic testing will provide a basis for more effective methods to ensure the health of individual workers, but that preventive actions taken on the basis of such testing might violate existing legislation. So what do you do now? Well, before thinking about genetic testing, and I bring this to occupational audiences generally because they're the ones responsible for developing programs, but I'll bring it to you too, as you may be asked to have similar considerations around criteria for testing. Obviously, if one is doing genetic testing for a variety of reasons, including related to understanding how to give advice about somebody's diet. If you're into nutrigenomics, the gene product really must be relevant to that pathophysiology, and the function must be associated with an exposure. It sort of goes without saying, obviously, this is as it is in any other type of exposure. There must be a substantial magnitude of association, and the frequency in the population must be sort of measurable and substantive. So to develop a code of practice for the conduct of genetic monitoring of employees exposed to hazardous substance, one must then first consider published guidelines. And I will just briefly, I'm looking at the time, I want to make sure I get finished. There are guiding principles already published in a variety of other countries related to genetic screening in occupational settings, including in the UK, in Australia, and some verbiage coming out of the US as well. Now this slide's pretty busy with words, so if you focus on the red, that there is strong evidence of a clear connection that the condition seriously endangers one's health. You're not going to sort of do genetic screening for a paper cut because the consequence is not severe enough to warrant that kind of testing, and that the dangers cannot be eliminated or reduced, which is an expectation in terms of managing occupational exposure. One of the primary mechanisms of managing occupational exposure to a particular substance in the workplace is elimination or reduction of the exposure. But if for some reason that is not possible, and an example, given that I do some work with some aviation providers, is that aircraft noises, I mean, a plane starts up, it's noisy, you can't make the engine not be noisy? Well, you can reduce the noise to some extent by ensuring it's efficient, but you sort of can't have the plane start up in a noise controlled box, right? So there are some situations where the dangers can't be eliminated or reduced. And those are the situations in which, if there's a clear genetic link, that the implementation of a screening program might be the most relevant. As well, you know, if there's a reliable method of testing, that's also relevant to enabling. So this is a comment from the Australian government, which has made a recommendation to permit the collection and use of genetic test results and family medical history for the purpose of susceptibility screening, subject to limitations. And so, you know, I would encourage people to think about, when they take a family history, what they're actually doing. And furthermore, when they take an occupational history, is there anything in there that suggests there can be more that can be done? And so this is the comment that I just highlighted in the last slide, the recommendation to permit the collection and use of genetic test results for the purpose of susceptibility screening. And some jurisdictions have actually already adopted this approach. In Denmark, for example, employers are permitted to collect health data where it's relevant to the employee's ability to perform a specific type of work and determine that employee's risk of contracting illness if the condition of the working environment make it reasonable and appropriate to do so for that individual. So it's already happening. The guidelines as well indicate, of course, that that kind of testing should not be conducted if the danger can be eliminated or reduced by other reasonable measures. So of course, this is like, it's really like PPE for COVID or for any other thing. PPE is the bottom of the control hierarchy of exposure to, or management of exposure to a toxin or to a hazard. And I'm not going to spend a lot of time going over the American positions on this, but it is interesting that due consideration be given to the quality and reliability of the tests and the predictive value of the results, of course. So we're not at a point in a lot of our test capabilities that we would really think that the quality and reliability of screening tests is high enough to implement them in many ways. But this is just a hint to what may be very common in the future. So potential criteria for implementing genetic monitoring in the workplace. This list, I think we're getting to points of redundancy now where I've said some of these things before, but obviously protection of privacy and confidentiality, you know, goals of the program and the clinical utility are all things that would need to be in place before one sort of willy-nilly started doing genetic monitoring. And then there are as well other papers that indicate when such testing would or would not be justified. And at the very bottom of that table, you see may be justified if there is a polymorphism in combination with an occupational exposure that commonly causes a fatal disorder that does not occur in the absence of the mutation. That would justify genetic screening, as would control the exposure from the workplace is not practical. So there are some debatable points, you know, genetic testing versus other monitoring, and whether or not really there's enough similarities over the course of time, these things merge to be the same thing. Are they the same or are they different? And furthermore, if one is to do genetic monitoring, should it be group-based or individual? Because there are some proposals that entire groups be monitored, and particularly, for example, with beryllium, versus whether or not an individual should be examined specifically for their particular susceptibility. And then, of course, comes the issue of consent and the individual's willingness to accept or not accept risk for themselves, and whether or not accepting risk for themselves impacts only themselves or impacts others as well. And so Here is the conundrum, which is really the thought-provoking component of this talk, which is acting on the basis of genetic information to better protect the worker and not acting on that information and thereby failing to protect the worker both violate the standards of ethical conduct. And so what do? Do you not test? If you don't test and you fail to protect the worker, you're failing to protect the worker. If you do test and you act on the basis of that information, that could also be against existing legislation because it could be discriminatory. So I don't have a good answer for that. I just put that forward as a thought-provoking conundrum that I think ultimately in the long run will extend beyond the scope of the occupational medicine realm and into other areas. I personally think there are ways, justifications to implement reason testing in an occupational setting, but of course they all have to have the balances and controls to make sure that there's the result is not an outcome that includes any discrimination. So what about the future? I'll just finish it off with a quick slide to say, how do we integrate this with artificial intelligence? That may be very interesting. Machine learning can figure out genetic mutations. You used to be able to, my very first slide was, how long does it take to sequence the entire human genome? And, you know, we can do that very quickly now. And how hard is it for machine learning then to figure out genetic mutations and which ones translate into health or illness? And then I think a bigger challenge is going to be gene interactions among genetic changes and that concept of epigenetics and the light switch going on and off, and what behaviors, actions, lifestyle factors, occupational, environmental exposures do we have that flick various switches on and off over the course of our lifetime. So there is new, I can't say new anymore because it's not new anymore. We're dating back a couple of years now to an AI institute in Toronto with a lot of federal funding to embark on developing AI, and AI in medicine is another talk, which I can talk about what a lab I'm working with in Hamilton is doing around trust in AI and what it would take for medical practitioners to actually trust a machine to know more than we do. But the fact is, when it comes to the amount of data in a human genome, and then we start looking at that on a population level, it's just enormous. And so I'll leave it at that. In the PDF that I provided, Kathy, I have lots of extra slides, which I'm not going to go into. So if there are folks in the audience that are interested in other references and things like that, I've put those into that. I suppose I could stop sharing. Would that be appropriate now? I'll stop the sharing now.
Sure.
And then we'll be just back on the face-to-face. And if there are comments, questions, or points of discussion, I'm happy to take any, but I will say I hope that you found the talk stimulating and thought-provoking. I know when I start talking about Watson and Crick and the DNA, people go, yeah, I understand that. And then people say, yeah, I understand occupational exposure too. But the concept of being in a conundrum whereby using genetic information and yet not using the genetic information, both are unethical. Anyway, so I'll leave it at that, and I will open the door. And for those who are interested, I think the recording will be probably put on a link somewhere, I guess.
Does anyone have any questions? You can open up your mics and ask them.
Or comments, I guess. Just discussion would be good as well. If it's just open discussion, doesn't have to be a question, whatever.
Well, there's one in the chat box. I don't know if you
Nope.
see it. It's thanks.
I actually don't see it. Oh, there it is. Hold on, I see it. Yes. Oh, Wendy, thanks. I'm glad you enjoyed it. One of the interesting things I think for this kind of talk is people will perhaps walk away and think about their own genetics and how little we know about. And now I can tell you, like, every time I put food in my mouth and every time I, don't exercise, I think to myself, am I flicking some sort of genetic switch on or off right now? And when I stay up late and I don't sleep, and that's another thing. And, interesting, I brought a couple papers. I should say them because we're not overflowing with questions, but I will say that there in the Personal Genome Project Canada, it's a study, the first 56 participants where they mapped the genome of 56 folks. 25% of the participants carried medically relevant genetic variants with possible immediate health management implications, including 6 pathogenic variants, 7 risk variants for cancer and chronic common diseases. And then almost all, which is shocking, all participants had other medically actionable findings, including recessive variants of common carrier states, or variants that underlie atypical responses to dozens of common medications. So those were the results for the first 56 genomes, and they found medically relevant and actionable information in 25% for sure related to illness and 100% related to things that could be useful for those people's knowledge. So it makes you want to run out maybe and get your genome sequenced, if only they could tell you what to do with all that information and how that might help. They're starting to do and find actionable genetic relevant findings for things like chronic fatigue syndrome. That's a very poorly understood situation, as well as the implications for sleep, circadian dysynchrony, a variety of other genes. So anyway, I just find it personally interesting that when you sequence a genome of a human, you're almost guaranteed to find something you can action clinically as a physician or a medical practitioner, but how to actually implement that maybe will take us decades yet to integrate into our healthcare system.
Very interesting talk, thank you. And it just seems to me such a big sort of thing to try to integrate, and especially the epigenetics, because presumably, with one exposure, and also the epigenetic changes would probably differ depending on the cell type. Like maybe the aromatic amines, it more affects the epigenetics of the bladder cells and maybe less so the hepatic, other things, hepatic epigenetic changes or mutations in other areas, maybe not as affected. So then it's just a huge undertaking to try and understand what's going on.
Yeah, that is so true. And you know what else too, is that you sort of think, well, it's also perhaps the timing and the lifespan too. Like if you flick this gene on before the age of 10, if you flick this gene on before the age of 50, and also the fact that in so doing, as you said, some of those genes could also be silenced over the course of time too. So it just seems like this constantly moving target at a cellular level where there's so much going on. It makes you want to just take a step back and go get enough sleep, get some exercise, eat right, get back to basics somehow, because how on earth could you integrate the amount of information into some practical, advice, and knowing how many variables there are?
Great point, thanks.
Kathy, if I could just ask the audience, like we had talked about before too, if there are those online that are interested in hearing other topics, could you please let Kathy know? I usually come back maybe once a year. So if there are topics of particular interest that you would like to hear about, if it's within my area of teaching ability, then I'd be happy to take your input on what you might like to hear about next time I'm back.
I can always send you my list at the end of the year and
For sure.
browse through.
Yep, perfect.
Any other questions, concerns?
Yeah, I just had a curiosity question. Have you had like the 23andMe test, for example? Is that something that would be an accurate test to have done? What's the difference?
Well, that is a direct-to-consumer test, right? So that is one where you pay and they give you a bunch of stuff back. They probably keep your data as well. I don't know. You probably have to sign a disclaimer that your genetics are going into some big bank that they're going to use for a multi-AI investigation. I don't know the answer to that. But the answer is early on, when they first came out, I did do it myself out of sheer curiosity and because the cost was not prohibited. So I was just interested in how the results would be presented to me and whether or not they were nonsensical or if they made sense. And they were interesting. Did I take any immediate action on it? No. I would now my next area of interest is to, if I redid it now, how different would it be from the tests that I did previously? I think if those tests were, they have some value in the sense that they will identify some very significant genes known to be associated with illness, and they actually present the results to you in an enclosed envelope where you have to decide beforehand whether you do or don't want to open the envelope. And even if the envelope is negative, you still have to decide because you know that it might be positive. And so in those cases, like if, for example, they were to identify a BRCA1 gene for breast cancer, something like that, you know, I would have probably been quite interested in that finding. Would I have trusted that test? No, I would have, though, trotted right off to my healthcare provider and said, I need to get this done in a more academic way. We need to look at this and figure out whether or not this is real and does it have any meaning. So, you know, a lot of the things they're testing for, you know, whether or not you find broccoli to be bitter, don't really have a huge impact on your life. It just explains some funny idiosyncrasy between why you don't like broccoli and someone else does. But there are a few findings that if that test did come back with something, that I would seriously take it to a healthcare provider and say, let's have a look at this. It might have some meaning and we might be able to do something now before it's too late. And I'll give you a little story too, like a little anecdote. A colleague of mine, as I said, I work with some space agency colleagues who were very keen to enable to the ability possible of a well-trained astronaut to continue flying after the discovery of some cholesterol issues, and then genetic testing was done, and the identification of you know, certain genes, APO gene related to a risk for high cholesterol was identified, and then the question was, okay, well, how do we manage this? We know the issue is not only one of diet and exercise; it's one of genetics. So we may have to take a different approach to managing the situation. So there are certainly circumstances where that knowledge can lead you down a path of wellness. But if you don't want the bad result to find out that you have a gene that suggests you're going to get Alzheimer's early, yeah, be prepared. It's a word of warning because they can identify those kind of things as well.
Thank you.
In this day and age with genetic testing and insurance claims,
Mm.
is that a conundrum?
I think it is a conundrum at the moment, because if you, and in fact, early on when those direct-to-consumer tests were coming out, there were some concerns that if people actually even took those tests, would they then be obligated, if there was a finding on that test, to then declare to the insurance company? Because the way the questions are worded in some insurance questionnaires are, do you know or have you any reason to believe that you might be at risk for X, Y, or Z? And if you've taken 23andMe and you know that you have a certain gene or something that might, but might not. So the question is, really, how do you respond to that? My personal response to that would be that it was not diagnosed by a medical practitioner. It was only a direct-to-consumer test, which has some limitations to it. And so I don't consider that to be a type of test that would drive me. If it was diagnosed as a result, that something was identified on the test, I went to a medical practitioner, we did some additional testing. But I don't actually know the answer to that. I think it would be one that one would want to understand the stance of one's own insurance provider and one's own healthcare practitioner as well, on whether or not the results of those tests would constitute a requirement for a declaration. I don't know the answer to that, really. But also to know that when we talk about genetic testing, the insurance will ask questions about family history. So they're probing that realm already, right? They're already asking about family history. Did any of your parents have? Did any of your parents have dementia, renal stones, breast cancer, cardiac, whatever? They have a whole plethora of tests, questions they ask about family history. And that's a lab-based way to get genetic information.
So true. Any other questions before we wrap up? I'm not hearing any. I'd like to thank you very much for coming once again, Dr. Sari. That's I always learn a wealth of information whenever you present, and I'm sure the rest of the team does as well.
Good. I'm glad you enjoyed it. Keep inviting me back. I'll keep coming.